Hello and welcome to Health Check from the BBC. I'm Claudia Hammond. In a moment, Japan has declared a flu epidemic and is seeing higher numbers of cases than usual for the time of year. We'll ask what this means for global flu predictions. And can you imagine going online, finding some medical research, volunteering to take part, and then faking all your answers? Strange thing to do, right? Well, later on we'll hear about the problem of imposters in health research. And to help me today, I have family doctor Ayan Panja. It's a bit bizarre, isn't it, that?
I mean, it's astonishing, and as a doctor, it makes me worry a lot about the research I've read and how much of it is down to imposters.
Yeah, well, we'll have more on that later. And what do you have for us today?
Well, I'm really excited about this nasal adrenaline spray, which is going to change the lives of people with allergies.
Well, before all that, Japan has declared a flu epidemic, with cases surging earlier than would be expected in a typical flu season. Now, Ayan, you've been taking a look at the figures. Who's most affected?
Firstly, it is not really the peak of flu season, so it's come much earlier than you would expect flu to hit. And secondly, it's absolutely rifled through the population. So at the moment, there are just over 9,000 cases. And in terms of the people that have needed hospitalisation, about half of them are children under the age of 14. Just to give you an idea of the scale of this, they've shut over 100 schools in Japan. And when you're shutting schools, I mean, that is pretty serious.
And why is this so unusual for Japan? I mean, do they know why rates are so high?
Well, there's a theory. So the end of winter in the southern hemisphere, in places like Australia, has just ended, I guess, and there was a flu strain there called H3N2, and if you look at other countries like Malaysia, they are also seeing a spike in flu, and a lot of their cases are from that strain. So the theory is that that is probably what has happened, Japanese tourists or Australians going to Japan, vice versa, so that is probably what's caused this.
Now, sometimes you can spot patterns of outbreaks in one hemisphere of the world which then repeat, say in the northern hemisphere as winter approaches there. What does this outbreak indicate for flu rates for the winter season in the northern hemisphere?
Well, it's difficult to say. So it's unlikely to be directly linked. I mean, certainly for Asia, I think this is quite significant because we now know that there's a spike in Malaysia. South Korea has also just issued an advisory on flu in the last week. And of course, Japan, we know things are really quite severe there. So in Asia, I think the countries there need to be sort of on lookout. As for Europe, I think time will sort of tell. Sometimes there's a link between the strain that you see in Australia and the strains that you see in Europe. And every year, the Department of Health, for example, in the UK, will look for the strains that are most likely to come and affect us. So hard to say at the moment. Yeah,
so in the Northern Hemisphere, many people will be getting their flu vaccines now, ready for the winter. Do we know if the newest flu vaccine will be effective against this strain we're seeing in Japan?
It's difficult to say. In the Southern Hemisphere, the flu vaccine was around 50% effective. It varies year on year. So one would hope it would be similar in Europe.
Thanks for that, Ayan. Now, in recent years, online health studies have allowed researchers to reach a far wider range of people and in far greater numbers than used to be possible. So if you want to know how patients with a particular disease experience their care, then an online survey might be a good way to do it. There is just one problem. Some of the participants have turned out to be imposters, lying about having a disease instead of responding truthfully. And then there are bots filling in hundreds of online forms when they're not even human. Now, when imposters take part in health studies, it not only undermines the validity of research results, but also the clinical and policy decisions that are built on them. Eileen Morrow, who's a doctoral research fellow at the University of Oxford, warns in the British Medical Journal that imposters are on the rise. And I began by asking her about her own experience with them.
My very first experience with an imposter, I was asking children and parents about their experiences of having leg surgery. So I was asking people to sign up online, and then I was contacting people by phone. And I did realise, before I had actually interviewed anybody, a lot of the mobile numbers I had been given didn't have enough numbers in it. And I also noticed that I had a number of people giving me postcodes for Buckingham Palace. And then when I came to interview my first participant, it was supposedly a surgeon who performs leg surgery. And it was a difficult interview. I couldn't really hear him. He was giving me unusual answers. For example, couldn't really tell me what hospital he worked in. So I had just asked him for his GMC number, which is the General Medical Council, and every doctor has this in the UK. It's what you need to be registered as a doctor. And he became really upset when I asked him about his GMC number and hung up on me really abruptly. And that was a concern, so I double-checked the online form that people were signing up to and realised that as soon as this person had hung up from this call, they had re-signed up to my study with the same name, the same email address, but as a child who'd had leg surgery. That was when I really twigged that there were people signing up to this study who were happy and willing to lie to me about who they were.
And so is this something that's happening mainly with online studies?
Yeah, so I want to be really clear that things like drugs trials, vaccine trials, surgery trials are really unlikely to have been impacted by imposter participants, because in order to take part in that type of trial, generally you have to have been recruited face-to-face by a healthcare worker, so either a doctor or nurse or an allied health professional. But for the type of research that this has really been impacted by are things like surveys that can be entirely delivered online. And we typically use surveys to ask people about their experiences. For example, one of the studies that has been really impacted by imposter participants was asking people about how they experienced communication with their doctor while they were having treatment for ovarian cancer.
And do you have any idea why people are doing this? What would the motivations of an imposter be?
That's a really important question, and I think one that we don't necessarily have a confident answer to at the moment. We think they're financial, and certainly that has been my own experience as well. I've had several imposters emailing me to say, could I have an Amazon gift card instead of the gift card that the study is offering? But it's important to know that not all studies that have found imposters within their data sets have offered financial incentives, and so there's some other motivations that have been proposed, and that might include just boredom, curiosity about health research, or even potentially individuals or a group targeting research that they don't agree with in order to disrupt it.
It's curious to see why somebody would, not agree with some research that's about communication around ovarian cancer, though, isn't it? It seems really odd.
Yes, absolutely. And that study in particular was offering a financial incentive, and that is quite complicated to try and unpick, because what we don't want to do is to accuse people who are genuine participants and really want to share their experiences, but maybe have less typical responses than we would expect. And we don't want to go back to them and say, we think you're an imposter, we're not going to pay you, and we're going to take all your information out of the study. So it's something we have to be really careful with finding the balance on.
And when you interviewed the person, then I could guess that's relatively easy to try to work out whether they're an imposter, particularly when he panicked when you asked him for his GMC number. But when it comes to an online study, how are researchers even telling that there are imposters there?
As a research community, there's been a number of papers published telling people about the red flags that they have noticed, looking for things like really short completion times. So if we would expect a survey to be filled in 20 minutes and they're being filled in 30 seconds, that's definitely a red flag. Responses that have been submitted outside of typical waking hours, really incongruent responses to open-ended questions. So again, in my own experience, I put out a survey, and one of the people that I suspected of being a bot, when I had said to them, what condition did you have that meant that you needed to have leg surgery? They just wrote none, which is a really unusual response. Other things have been patterned responses, so maybe someone just clicks the first response for every question. Like I say, implausible home addresses like Buckingham Palace or 10 Downing Street in London, which is the Prime Minister's address. But these are all detection measures, and I think what we need really is prevention measures as well to try and stop people from taking part as imposters, rather than just trying to detect imposters at the back end within our data sets.
How common have you found imposters to be in research? Do you know what sort of proportion of responses that people are getting are fake, if you like?
So our understanding of this is really based on people publishing when they check for imposter participants. And not everybody does, because it's not the primary focus of their research. It's a bit of an incidental finding. But the studies that have published have really varied and ranged from 3% up to 94%.
94%? Wow.
It can get very high. And if I actually go back to that ovarian cancer paper that I was talking about, that's the study that found 94% of their responses. They were very confident were imposters, but actually the remaining 6% they suspected as well. So they didn't think they had any genuine responses in that study.
So that would completely invalidate that research. This must be horrible for researchers. You put all this effort into trying to do really good research that then policymakers can act on, that doctors can act on, decisions can be made on that, and there's people trying to ruin it. Is there a way you can design a study so that it makes imposters easier to spot?
One thing we can do is we can add what's called a hidden question within a survey or within a sign-up sheet for a study. So that's a question that if you're just scrolling through the web page that you see yourself, you don't see that question, so you wouldn't answer it. But in the coding behind the web page, this question is included within the coding. So if somebody answers that question, they're really likely to be an automated software that's scrolling through the coding rather than actually scrolling through the web page as you would see it yourself.
Oh, that's really clever. So you can spot the bots that way by giving them a trick question to answer. I like that.
Yeah, absolutely. But if you haven't included that in your study design and you're just trying to look for these people at the end, it's a real risk that we're excluding people that have real experiences to speak about.
Eileen Morrow from Oxford University. Hey, and I was staggered by by the whole thing, really.
I am really shocked. I've got so many thoughts. Firstly, why haven't I come across this before as someone who's a practicing doctor? Secondly, 94%. I mean, I was expecting a figure of maybe 20% maximum, but that, as you said, completely invalidates that research, and it's heartbreaking. I mean, it's sort of one of those things where people are deliberately trying to ruin research and science.
Yeah, worrying, isn't it? Mm. Now, if you have a life-threatening allergy to peanuts or bee stings, say, then you may well carry an adrenaline pen with you, sometimes called an EpiPen, ready for you or someone else to inject you if you suffer an allergic reaction. But now there's a new way of getting adrenaline into your body in an emergency via a nasal spray. You can get it in Germany and the US, and from this week on the NHS in the UK too, and other countries are following suit. And this is the first needle-free alternative, but with the usual kind, as a family doctor, are you teaching patients how to use these injections, and what sort of struggles or worries do you see?
Yeah, it's really interesting. People who've had adrenaline injectors for many years because they have a life-threatening allergy, if they haven't used them recently and they're asking for them on repeat prescription, sometimes we bring them in and ask them to show us what they do with it. Now, there are 3 types, and so they all work slightly differently, and it's amazing how many people don't quite know what to do. So that's the first thing that is slightly clunky about the pen. Secondly, people don't like needles. A lot of people don't like the idea of, stabbing themselves with a needle. Of course, it's in an emergency situation and you would have to do it. But I'm really, really excited about this because I think this is going to change the way we manage allergies, and I'm really, really looking forward to it being rolled out.
Yeah, why do you think patients might prefer a nasal spray option, apart from not having to use an injection, not having to put a needle in yourself?
It's much more convenient. The second thing about this nasal spray is that it's not, you don't have to really think too much about the temperature in which you store it, so the pens, very high or very low temperatures can affect the adrenaline in the pens. And also, apart from the convenience, most of us are used to the idea of nasal sprays. It's sort of much more, it's demedicalising an already very stressful situation. And I think less likely that it will go in wrong. How hard can it be to sort of stuff something up your nose compared to sort of stabbing yourself in the thigh? I mean, one of the things we hear about when we get training on this is that the number of people that know that someone is having anaphylaxis and actually sort of use the pen on themselves rather than the person that they're meant to be administering to.
So how does this new nasal spray work? You spray it up your nose, presumably?
Yeah, so a nasal spray essentially gets whatever drug is in it, in this case adrenaline, through our mucous membrane. So that's the inner lining of our nose. Lots of drugs are administered this way. Many of us use nasal sprays for other reasons. And the way the adrenaline works in anaphylaxis is that it does several things. One is that it relaxes smooth muscle, which eases the ability to breathe, which is often something that you find in anaphylaxis, breathlessness. It also raises blood pressure, which supports blood flow to organs, and that's another thing we see in anaphylaxis. The blood pressure drops, and your essential organs stop getting enough blood flow. So that's how it works mechanistically.
And is it just as effective as the injections?
It is. In the study, it's as effective. So they measured the amount of adrenaline that was in your blood, and actually it's at a therapeutic level when it's delivered as a nasal spray, so it works.
And what if you have a cold and your nose is all blocked up? You can imagine it not getting through.
It still works, yeah. That was one of the first things I thought of, but it sounds as though you'd have to literally sort of cement your nose so that nothing could get into it. It would work if you've got a cold.
And how available is it worldwide at the moment?
So it's available in Germany, it's available in the US, it's been approved here in the UK. It hasn't been rolled out as yet, but that should happen very soon.
It's such an interesting new way of doing it, and I guess in time the rest of us might need to know what to do with these sprays if we come across someone, if we've got a friend who needs us to do it.
It's a really good point, and what I would say, it's going to be a lot easier than it would have been with the pen. Actually teaching someone to use the pen is even as a medic, actually, it's relatively threatening, when you're being trained about this. And as a layperson, unless you're the parent of a child with an allergy or you have one yourself, most members of the public, it's quite a fearsome thing having to administer it, whereas I think this is much less threatening. So the training should be fairly straightforward, but you're right, it's going to be something that we need to raise the public awareness about.
And what sort of difference do you think this will make for people who have allergies? Because it's really stressful, isn't it, knowing that something life-threatening might happen to you?
It really is, and the parents who have children at schools, for example, who have severe life-threatening peanut allergy, they will tell you how much they worry about school trips, how much they worry about sleepovers, things that other people take for granted. And I think this nasal spray will really change their lives because, especially when you've got a young child, you're able to sort of defer responsibility, I think, at a younger age, although that would need guidance. But, I think this is going to be absolutely game-changing.
Thanks for that, Ian. You're listening to Health Check from the BBC. I'm Claudia Hammond, and my guest today is family doctor Ayan Panja. Now, it's notoriously difficult to study the effects of drugs on pregnant women due to the risks to their unborn babies. But a new trial is doing just that, investigating the effects of common malaria drugs on women who are very early in their pregnancy to expand the options they have available if they contract the disease. Malaria is particularly dangerous for pregnant women, increasing the risk of mortality, miscarriage and premature birth. And currently, this trial is recruiting pregnant women in Burkina Faso, Kenya and Mali. I spoke to Professor Kassoum Keantayo, who's running the trial, which is supported by Medicines for Malaria Venture. He's an epidemiologist at the University of Sciences of Bamako in Mali, and he told me what treatment options women have at the moment if they do catch malaria at the start of their pregnancy.
We have already quinine, which is also widely used. But quinine is really a difficult treatment because of compliance. So you need 6 tablets per day for many days. And you also have to add another drug. So that's really very hard to support. So the compliance is very hard. So now in this trial, we wanted to bring 2 more options in addition to what we have already.
So at the moment, there's just one option for women who are in the first trimester of pregnancy. Why do you need more options if there is already one drug?
Yeah, we need more options because the burden of malarial pregnancy is very important. In 2023, over 12 million pregnant women are exposed to malaria in sub-Saharan Africa, and over a third of all pregnancies in Africa, corresponding to 36%, were exposed to malaria. So if you have only one option, drug resistance can come, and if there is only one option, we may face difficulties to treat malaria. But if you have more options, then in case of failure of one of the drugs, you have other drug to treat malaria.
Do you find that pregnant women are nervous about taking medication even though they have malaria?
If they're sick, very sick, it's easy to convince them to take malaria medicine. But if they're not sick, if it's only for prevention, it's sometimes very difficult. But what happens is also, even if they are sick, they don't want to take modern medicine because of fear, and they thought that the medicine can be toxic for the baby. So that's actually, the main issue that we have usually with the pregnant population.
How easy is it to recruit women into this type of study?
Well, it's a very challenging situation because in our social cultural context, pregnant women don't want to know, they don't want people to know that they're pregnant. So it's a hidden condition until it becomes prominent. This is our society. This is the reality of our society. And because of that, they attend INC very late and therefore don't have access to prevention and treatment tools. So this is really the difficulty that we have in recruiting pregnant women.
So how are you managing to find women if many women don't tell anyone that they're pregnant at the beginning?
It's really challenging. Before we start the study, we conducted a formative research to know exactly what are the issues and how together with the community, we can come up with a solution. So we were able to identify all the stakeholders which can have an influence in the community. We also work with the women's leader in the community, also with the religious leader. Together we explain the consequences of malaria and why we want to treat malaria at the early stage of pregnancy. And what we did is we focus on community health workers. So with community health worker, they do door-to-door visits in the household to screen for pregnancy. So if pregnancy is confirmed, then this is a potential candidate to be in the study. And this is exactly, what we are relying on to increase our chance to get a woman in the first trimester from the community, but also from the health center.
Well, let's hear now from the very first patient to take part in this trial about why she chose to participate.
I think it's a good initiative because it helps us, pregnant women, get proper antenatal care without any problems. I heard about it in my community and I chose to participate because I wanted to. If you're pregnant like me, please go for antenatal care as early as possible. That way, if you have malaria, you can get the right treatment in time. The study helps protect your pregnancy until delivery, and it can save both you and your baby from malaria.
the very first patient to take part, and Kasum Kayantayo. Now, Ian, there's one more story I'd like to ask you about before we go, and it concerns ultra-endurance athletes testing the limits of the human body. Have you ever been tempted by ultra-endurance sports, like, I don't know, running 10 marathons in 10 days?
Absolutely not, although I've got some friends that certainly are.
And in this study, what counts as an ultra-endurance athlete?
Well, I think in general, ultra-endurance athletes are people who take part in some sort of sporting activity that takes, endurance, 4 or 6 hours, for a long period of time. In this study, they were elite, high-performing athletes, the best of the best, so world-class athletes, and they picked 14 of them doing ultra-endurance activities, whether that's cycling or running or triathlon, and often they do multi-day events, where they're literally burning lots of calories every single day for maybe 5, 6, 7 days.
So researchers were looking at something called the metabolic ceiling. What is that, and why is that important in ultra-endurance sports?
So we kind of know what basal metabolic rate is, which is the number of calories your body needs just to function, the bare essential in terms of calories. And our metabolic ceiling is almost the opposite. It's the maximum number of calories that your body can burn off. And what they looked at in this study, so they were looking at these ultra-endurance athletes, 14 of them, who often do multi-day events, just to see what was happening to their metabolic rate. And they did this by labelling a type of water with a sort of, when I say labelling, I mean it was something that they could track and measure through the body. And what they found was that a lot of these athletes were burning, 6 or 7 times their basal metabolic rate, particularly during these multi-day events. But after a while, the sort of ceiling, their metabolic ceiling, the maximum number of calories that they could burn after a while came back down to 2.5 times their basal metabolic rate, which kind of suggests that there is a metabolic ceiling. Even these, superhuman people that are sort of exercising to extreme cannot kind of get beyond that 2.5. And that sort of means the body kind of almost corrects itself after a while. The only way you could try and sort of beat that is by overdoing it effectively, by doing that kind of ultra endurance every single day. And then if you did that, the danger would be that you would start to shrink, you would start to lose muscle mass and effectively start to disappear.
There's a limit to how much they can increase this by, but I wonder what this means for the rest of us mere mortals.
For us, I guess it's not as much of an issue, because most of us are not going to be burning that level of calories. Interestingly, also it says that if you were to do 11 miles of running a day for a year, that would hit your metabolic ceiling of sort of 2.5 times. But
that's quite a lot, isn't it?
That's a lot of running, and the counterbalance to that is injury and also the risk of exhaustion.
Yeah, I don't think I'll be doing that. And you can find that study in the journal Current Biology. Thank you so much, Ian Panja, for joining us for Health Check today, and thanks to the producers Katie Tomsit and Hannah. Bye for now.